My hope through this and through my presentation I'm going to give you today is that I'm going to give you some information. My job is not to make this look pretty. My job is not to make you feel necessarily good. My job is to give you information so you are better able to appreciate and understand what you need to do and what the areas where you have influence over need to do in order to work towards a solution. I'm going to give you information that's likely going to startle you, that likely will frighten you, and I'm not doing that to scare you to get your attention, but the reality is the problem that we're facing is that bad. And I'd also like to thank my boss, Chris Peak, who is not here today, the CEO of Caramont, because he feels so passionate about this. He is giving me carte blanche to take whatever time I need, whenever I'm asked, to help involve myself in these activities. And he said, Todd, take the entire day. If that's what you would like, take the entire day. And so I'd like to thank him for his commitment towards this as well. So what I'm going to do is talk a little bit about opioids, and I'm going to tell a story, and part of it, I think you deserve to understand what all this came from, because it can conceptualize this. And I'm going to end a little bit with what are some of the things that lead to stress. Dr. Taormina is going to be following afterwards, and she's going to get into more information and fill in some of the holes that I'm leaving with more detail and give you a more defined scope of what's happening locally and regionally. I'm going to speak a little bit more nationally. So to start, the irony is something absolutely so beautiful can create so much despair and hopelessness. So where do opioids come from? They come from poppies, other than now the synthetic opioids that we're dealing with. Poppies are a beautiful flower. And nearly 6,000 years ago, in the cradle of civilization in Mesopotamia, people learned that if they scratched a poppy, the resulting fluid that would leak out when it dried would create euphoria. It would alter moods and would also magically help with pain. And that was called opium. 6,000 years ago. In fact, I think part of the state of human civilization is one of the most, in nearly every primitive society, they've learned how to either create mind-altering drugs or ferment something, okay? And that's part of the human condition. So the ancients used this. They used it as a stimulant in some situations because lower doses of opiates can become that. They used it to help fight depression because, yes, opiates do fight depression because they relieve stress, and they used them for analgesia. They used it basically by smoking it or ingesting it orally because there weren't any other vehicles for consuming it at that time. And many of you may remember from your school history classes, the areas of abuse that were, the countries that dealt with most abuse was mostly in Middle and Near Asia, and that was the opium dens. The world completely changed in 1805 in Germany when morphine was discovered. And it was named after Morpheus, who the Greeks described as the Greek god of sleep. And it was named that because of the sedative properties that it found. It was rapidly commercialized and was sold as a panacea, which means it fixed multiple different ails. And it was widely available in markets. And you could just consume it for whatever problems that you had. Oftentimes it was used as an antitussive to prevent coughing. And remember, at that time, tuberculosis was extraordinarily widespread. There weren't any effective treatments for it. So people chronically coughed. It was used to prevent diarrhea. It was used to elevate mood. And it was used as an analgesic. Because at that time, there were no other analgesics. We didn't have ibuprofen. And we didn't have aspirin. And we didn't have Tylenol. Codeine then was synthesized from morphine. Codeine's, one of its active metabolites, is morphine. Codeine was synthesized a few years later, and it was commonly used, again, as an antitussive, as an antidiarrheal. as an analgesic, which is the fancy name for pain. So sometimes I'll revert back to medical terms. So if you hear me say analgesia, that means to bring pain relief. Currently, it is the most widely used opioid in the world. It's also the most widely abused opioid in the world. Heroin then was synthesized afterwards, and it was originally marketed by Bayer as a cure for morphine addiction, and it failed. Then, as many of you remember, and what I saw in my grandparents' medicine cabinets with laudanum, opiates then were started to be marketed and commercialized to treat multiple different maladies. Mrs. Winslow's soothing syrup, and she's giving to an infant, had opiates in it. The first recognition in this country that there was a problem really started in the early 1900s. In around 1914, something called the Harrison Act was passed, and it did the first small regulations of importing and exporting and manufacturing of opiates, but it was very minimal. And then a few years after that, the Supreme Court, because there were no other regulatory agencies like the FDA or medical boards or any other, the DEA, they ruled that doctors should not prescribe opioids to maintain addicts. So that's the first regulatory, I think, that I'm aware of that happened towards prescribers with opioids. But yet they were still extraordinarily widely available and were given oftentimes to veterans or to people in war theaters to help prevent problems, to treat all sorts of issues. So I'm going to now take a step back and I'm going to talk a little bit about pharmacology. And I hope that this early in the morning your eyes aren't going to glaze over, okay? And I'm going to try to keep it kind of high. But in order to understand a bit of the issues, you really need to understand some of the basic science. Okay, so if I say something you don't agree with or you don't understand, please just say, would you expound on that? Someone please interject. So opioids are chemicals, and they bind to specific receptors in the brain. And the best way to understand this is they mimic in some way a chemical that most of us have heard of called endorphins. Okay? And endorphins are a chemical that your brain naturally produces, that your body naturally produces to help relieve stress, to help have a feeling of euphoria. What produces endorphins? A great meal. Being in love. For me, when I have a great workout, hopefully sometimes I'll have that endorphin rush. Well, opiates have that same effect, except they're much, much more profound. They last much, much longer. So they mimic that wonderful sensation that we all like to experience. Is what's better than being in love, right? So synthetic opioids are much, much more powerful than anything that our brain makes, okay? And the challenge with these, and I'll speak a little bit more about this later, is how it completely rewires your brain, which is the issues that we deal with addiction. So I'm going to say a few things in this that I'd like you to remember, because I know I'm going to give you a lot of information. The first is that addiction is a chronic disease. Think of addiction like high blood pressure, or diabetes, or lung disease, or heart failure. If you have addiction, it is a lifelong disease. And until we understand that and start treating addiction like a lifelong disease, we will not succeed. Addiction is not something that people choose. There is no one that decides, I want to take this because I want to become an addict. Addiction occurs for different in people for different reasons, but most of it has to do with they are vulnerable because of their inherent brain chemistry and because of certain environmental pressures and stresses that they're under. Addiction is a chronic disease. It's not a choice. It lasts forever. A little more basic pharmacology. And Velma's smiling, and she cautioned me, don't get too deep into this, Todd. So there's different receptors in your brain. The ones that are important for opioids are mu1 and mu2, delta, and kappa. And again, I think information empowers people. And if I can give you some of this information, my hope is it's going to empower you and make you more savvy and able to help guide your decisions. What do mu1 receptors, what are they responsible for? Euphoria, making you feel good. Analgesia, pain relief. Confusion, nausea. And they actually have low abuse potential. Mu2, respiratory depression, which is generally what people die from opioid overdoses. They have cardiovascular, CV, GI, gastrointestinal, GU, urological effects. They create dependence and high abuse potentials. The delta, again, analgesia, pain relief, and they decrease your brain's ability to sense that oxygen is decreasing and its subsequent response. They also allow for physical dependence. So I want to briefly describe what happens when you overdose. When you overdose, your delta receptors are saturated with opiates, with a chemical. It decreases your brain's ability to recognize you are becoming hypoxic. Normally, when you're not breathing, your brain says, I need to breathe, and you start breathing more rapidly. And you get anxious. One of the most terrifying things for patients is shortness of breath. Okay? That's your body's feedback system to say, hey, danger, danger. You're not getting oxygen, you can die. You breathe faster, you breathe deeper, you become anxious. You have a sense of impending doom. You call our emergency responders to come take you to the hospital because you know something horrible is happening. Opioids impair the ability for your brain to recognize it, impair the ability for your brain to do then the survival things that it needs in order to treat it, like breathe faster, and impair your ability to have anxiety. That's what leads to overdose. And then there's the kappa responders, the kappa receptors. Now, why is this important? One is because I wanted you to understand what happens with overdoses. Does that seem clear? Did that explain that well? Okay. The other is, what are different effects that drugs have? This is a really high overview because they're really, really complicated, because some partially affect receptors and don't others, and some block some and don't others. But generally, the drugs that affect the mu receptors, which again, euphoria, pain relief, abuse potential, are the ones that we think about when we think about the opioid epidemic. Morphine, heroin, codeine, fentanyl, carfentanil. Fentanyl, 70 to 80 times stronger than morphine. Carfentanil, 10 to 100,000 times stronger than morphine. Terrifying doses. My practice is anesthesia and critical care. I use fentanyl every time I'm in the operating room. Its therapeutic index, that means that window that I can safely give, is really, really narrow. And that's one reason why I went to school for as long as I did, to learn how to use it. When people start messing with these drugs, there is no way they can remain in that safe window. And the more potent the drugs get, the smaller that window gets. So bad that I know our first responders now are terrified and have policies in place how to manage overdoses, because if they even get a little bit of carfentanil on them, they will overdose. So what drugs block these? Narcan, naloxone, it blocks all the receptors. So when we give drugs to counteract the opioid's effects, what you're doing is you're blocking those receptors. So suddenly the brain recognizes it needs oxygen. So you start breathing. There's a lot of anxiety that comes with that as well. And our first responders will tell you oftentimes people aren't really happy they got Narcan because suddenly all the other effects of the narcotics have been unmasked. So the pain goes away, that euphoria goes away, but they're breathing. Methadone. Why do we switch people to longer-acting opioids? Multiple reasons. And this deserves a whole nother hour lecture in itself. And I'm not going to cover this, but what methadone does is it allows a few things. It reduces the craving that people have with opioids because of effect on another brain receptor. But also, part of the challenge with short-acting opioids like heroin is you have the euphoria and then the down. And the down is bad. And people want to maintain that euphoria, so they're always craving compulsively to get to that feeling. What happens with addiction is it's no longer euphoria. When someone's addicted, they're not euphoric. High is the wrong thing. What they are is they're trying to reach a state where they're not withdrawing. Does that make sense? When you're addicted, you're taking drugs not to get high, which is what early drug users use. You're taking drugs so you don't withdraw, okay? Methadone has a long half-life, so that up and down goes away. And it also reduces craving. So it reduces some of the compulsive behaviors that happen, which is why oftentimes we try to transition people on methadone or Stadol, butorphanol, which Dr. Taormina and her team will talk to you a little bit about, the unbelievable success that she's had leading this actually in the state with one of the programs to help women who are addicted and pregnant. Stadol helps by longer half-life, again, so there's less up and down, but it helps block euphoria as well. Okay? Does anyone have questions about this? Please ask. All right. I want to talk to you about three terms: tolerance, dependence, and addiction, because you need to understand what the differences are. And it's a continuum that happens. Tolerance is when the effects of a drug are less because of repeated exposure and desensitization the receptors have. So what happens, and most people see this with alcohol. People who expose themselves to alcohol every day can drink a six-pack and they behave normally. People that don't drink one beer or one wine and they're impaired. The difference is the body has become used to the effects of alcohol, so they develop tolerance to it. When people have chronic opioid exposure, the mu receptors become less sensitive to the drug. So they have to escalate the dose in order to have the same effect because they are tolerant. The alcoholic has to continually drinking more and more in order to have the same effect. It's the exact same thing. Everybody will become tolerant. Every person in this room will become tolerant to drugs if you have repeated exposure. Dependence. Dependence is what happens when your body requires the drug. And if it doesn't get the drug anymore, you have physiologic and/or psychological effects when it's not there. Dependence doesn't necessarily mean you're addicted. After 5 to 7 days of chronic opioid use, not abuse, use, you will develop tolerance. Typically, after 2 to 3 weeks of opioid use, people will have some dependence. That means when they stop taking it, they will know. They will have some adverse feelings. Okay? And I'm going to come back to that in a minute because it's really important to understand adverse feelings in low times of stress, okay. Adverse feelings when you're very stressed exacerbate problems and make you more susceptible to continued opioid or any drug use. Yes, sir.
Could you repeat that? What was the time frame on the?
So this is a little gray and a little variable, and it's different for every body and every physiology. But generally, within 5 days, people will have tolerance to opioids. So that means if you're taking 5 days of oxycodone because you had a knee replacement, you will notice the effects that you had initially are less after 5 days. Typically, within 2 weeks, you can develop dependence to opioids. Okay? Addiction. My training again is critical care and anesthesia. We have a lot of mental health experts in here who are extraordinarily better able to discuss this. And so if there's more questions about addiction, I'm very likely going to defer to their expertise. Addiction is a chronic disease. Okay? It is manifested by compulsive substance abuse or use despite harmful consequences. And this is important too, because what happens in your brain with addiction, you have less and less of a recognition and the ability to respond to all those bad things that you know that you're choosing because you're addicted, because you're not paying attention to your children or your spouse, or you're financially irresponsible. Your brain chemistry starts to become altered, so those types of things have less impact on you, and you're less likely to act upon them. This is also extremely important. 75% of people with addiction have mental illness. Mental illness is a chronic disease. We cannot treat addiction unless we treat the mental illness that the people typically have. It will be unsuccessful. Part of this is taking away the stigma of mental illness. Again, addiction. It is a chronic disease. It's not a choice that people make. Brains are rewired. They are rewired years, 4 years, and sometimes permanently. And the brains will forever remember the effect that drug had to relieve stress, which is why this is a chronic disease. Addiction, yes, sir?
A quick question on that. Is it rewired, or in some cases are people just wired that way to begin with? Or that, I guess I'm asking about the trigger that would affect either the existing wiring or the rewiring.
So the question was, is it rewired or is it the wiring somehow different that led to this? The answer to your question is yes to both. So some brains are more susceptible to this, and we're going to talk about some of those things shortly. But the rewiring, the neurochemistry changes that occur because of the addiction as well. Addiction impairs judgment, and that's the stories that break our heart. that we hear all the time where parents neglect their children. And they make every decision is centered around feeding that addiction, and everything else becomes unimportant. My own belief is that any person, me, my wife, my 2 daughters, anyone in this room, can become addicted if they are exposed to the drug and the right environment occurs. I think this is a critical thing that we have to understand, that we all are susceptible to this. If we can appreciate that, it will remove the stigma, just like the stigma that we have with mental illness. The more quickly we're able to recognize that this problem has the potential to affect everyone in the room, and more importantly, everyone you love, the more likely you are going to be able to energize yourself to help do what's necessary. So let's talk a little bit about some of the risks for addiction that you're talking with. And Dr. Taormina is going to discuss this a little bit further and in more depth. So what are some of the things that we know will put people at higher risk? Well, one is if there is a family history of substance abuse, or if you have a history of substance abuse, including alcohol. One is age. Believe it or not, I'm at higher risk at 52. One is a history of pre-adolescent sexual abuse. And I think our mental health experts will say that it's unlikely that anyone experiences this is left untouched in some way in their life. Why? Because of the stress that it creates. Then there are psychological disorders like ADD, attention deficit disorder, ADHD, OCD, obsessive compulsive disorder, or bipolar disease or mania, and depression. That probably in itself covers pretty close to 25 to 30% of our youth right now. Then, stress. This is really important. Our brains are more malleable to things when you're stressed. And you start to think about the environment that we live in now and our children are raised in. Think about social media, which I didn't have to deal with. 24/7, our young people are continually reminded of how inadequate they are on social media. They continually compare themselves to everything and they fall short. Talk about stress. Talk about the information overload that we have currently and what that leads to. This is why it's occurring now, in the time in our lives. The amount of stress that most of us have to deal with daily is extraordinary, and it's getting worse. And now you see why this problem is so complicated and is going to require a collaborative effort on so many parts in order to proactively manage this. I'm going to talk a little bit about withdrawal so you can understand what it is. And I think probably the most important part is the last 2 sections in that, because that's the part that most people don't understand or are aware of. Medicine is actually pretty simple because it makes sense. Withdrawal, when I think about withdrawal, all I need to know is what are the effects of the drug. Withdrawal is what happens when the effects are the opposite effects of that drug. So withdrawal from opioids, the symptoms, the immediate symptoms are the exact opposite of what the effects of that drug were. So when people withdraw, the acute withdrawal that we all think in our heads that if they get past that 7-day mark, they're good to go. The acute withdrawal is generally diarrhea, it's sleeplessness, it's high anxiety, it's pain, it's misery, right? It's everything that the opioid masks. And that generally lasts 5 to 7 days. It is not life-threatening. Alcohol withdrawal is. Benzodiazepine withdrawal is. Opioid withdrawal is extraordinarily unpleasant, but it will not take someone's life. That's what we all think about withdrawal. And again, in most of our minds, when someone gets to that acute withdrawal phase, we think they're good to go. Well, that's not really the way it works. And this is where the brain chemistry comes in. When you become dependent and addicted to opiates, your brain chemistry changes. So you don't sense pleasure the same way as everyone else. So the pleasure that I get from seeing my wife at the end of a day when she smiles at me, someone who has an addiction to opioids or has stopped opioids, they're not going to experience in the same way. They may not experience for 1 to 2 years. That incredible meal that we had over the holidays, they won't have the same pleasure from it. Their brains have now been rewired where those chemicals don't have the same effects. And that rewiring also occurs in an area of your brain called the prefrontal cortex. And that's that area in the brain that contains impulses. So when you're tempted to drive faster on the highway, that's the area of your brain that says, wait a second, you either slow down because it's against the law or you're going to hurt yourself or somebody else. Chronic opioid use rewires that, so that brain part of your brain starts to not have the same effects. And it won't tell you that your behaviors are putting you at risk. That all starts to occur when you're addicted, and those things don't go away for oftentimes years. So people that have been addicted, they will have insomnia. They may have depression. They may have all those things for years. They're unhappy. They're miserable. And their brains remember what it felt like when they were exposed to that drug. And the craving develops. And then something bad happens. They lose a job. They break their ankle. They have a divorce. A parent gets sick. A child has a problem at school. Or, as often in life, 2 or 3 things at once. And the stress becomes horrible, and they begin taking opioids again. There is a permanent rewiring. That craving never goes away, which is why this is a chronic disease, which is why we have to start preventing it. Some numbers to terrify you. 80% of the world's opioids are consumed in this country, yet we only represent a little over 4% of the world's population. Our life expectancy in this country has dropped the past 2 years for the first time in 40 years, and it's directly related to opioid overdose. Overdoses have quadrupled since 2000. And as Mr. Mathers spoke about, 100 people a day die. 800,000 people, to the best of our knowledge, recreationally used opioids last year. And we know that if someone recreationally uses oxycodone, they have a 1 in 14 chance to end up on heroin. Over 2 million Americans are addicted to prescription opioids, and over 500,000, are addicted to heroin. And those numbers are climbing. There were 30,000 deaths last year directly attributed to opioids. And someone in my business, we have over 700,000 ED visits in this country because of misuse. Opioids now are the leading accidental cause of death, and they cause more financial hardship to this country than automobile accidents. Let's talk about what's happening. Yes, ma'am.
Back one slide. Is that top number 8 million or 800,000?
The top number is 8 million Americans used opioids recreationally last year. I'm sorry, 8 million. Pardon me. So what's going on in our schools? Over 50% of high school seniors report it's easy to get prescription opioids. Over 50% of high school seniors report it's easy to get prescription opioids. Where are they getting them? Their family's medicine cabinet. For some reason in America, we feel compelled to hoard opioids. You have a surgery 2 years ago, and you got a prescription with 30 oxycodones, and you just want to keep them around, just in case, right? No. They need to go away. One of the things we need to do is rid all of our medicine cabinets of this drug. 80% of teens who use opioids get them from their family or their friends. 3.5 million young adults use them recreationally last year. Teens that smoke or drink are 2 to 3 times more likely to abuse opioids. And you've already seen some of the ADD, ADHD, the things that also put them at risk. I'm going to spend a little less time on this because I think it's probably less important about how we got here. Yes, sir?
Yes, is there a way we can get a copy of the presentation rather than just?
Sure. I will ask Britton to, this is for anyone's consumption. You can take this and do whatever you need to with it.
Thanks.
What happened in this country was in 1999, unfortunately, I'm embarrassed to say an anesthesiologist was part of this. But in 1990, an article was published in Scientific America that talked about the tragedy of what they called needless pain or chronic pain. And what it did is it suggested that if you treated chronic pain with opioids, you would not cause addiction. And it became the new standard of care. So the standard of care in this country, the standard which physicians are held to, became treating chronic pain with opioids. Pharmaceutical companies quickly opened that void by marketing and directly marketed to consumers and to physicians in the unbelievably effective way that they have. And as a consequence, opioid sales have risen, and the more opioids that are sold, the more addiction we have. Unintended consequences happen with 2 regulatory agencies. One was EMTALA, which is a law, a federal law that governs hospitals and how we manage patients that come to the emergency department. And that was to prevent patient dumping, which meant that you move one patient from a hospital to another hospital because they didn't have a source of payment. Part of EMTALA was they defined what emergency medical condition was. So they defined why you couldn't do it and what patients you could not move. And what they said was that you had to make sure patients didn't have emergency medical condition. And they said that pain in itself is a sign of an emergency medical condition, which forced hospitals and physicians in emergency rooms to treat pain in a different way. And as frequent as last year, our hospital was surveyed by the state, which means the surveyors come in because we had a complaint of a patient that had been to 47 EDs that we know of in this past year with chronic abdominal pain. And that patient wanted IV Demerol, and the ED doctor gave them Toradol, which is a nonsteroidal. And that patient filed a complaint with the state, and the state came in to survey us because to see whether or not we had treated that condition effectively. And when organizations and physicians are surveyed, they can lose their licenses if things go wrong. So you can imagine the unintended consequences of that. The Joint Commission, again, an unintended consequence. Hope they're doing things what they think is for best for patient safety. But in the early 2000s, they passed something called pain is the 5th vital sign. Blood pressure, heart rate, respiratory rate, temperature, pain level. and which forced hospitals and physicians to manage pain in a completely different fashion. And again, patients could complain if we were not treating their pain in a way they liked. And those complaints would mean surveys, and again, loss of licenses, fines, fees. And still, our hospital is reimbursed by the government dependent upon patient satisfaction. And 2 of the 14 questions that patients are asked are directly related to pain. So the compensation, still for physicians and hospitals, is going in the wrong way. Now, we're not managing that in the same fashion anymore. And Velma will talk to you a little bit about this early. Last thing I want to talk about is chronic pain. Chronic pain is pain that lasts longer than 3 months. What has caused chronic pain patients to become so susceptible to addiction? Well, first of all, 10 to 20% of Americans in their lifetime will have chronic pain. And the standard of care for decades was to treat chronic pain with opioids. And we know that brains are rewired when you have chronic opioid exposure. And we know that for some brains, when they're stressed, the compulsion will start and the addictive behaviors will start. And we know that chronic pain is really, really complicated. Chronic pain isn't just pain. It's psychological effects, it's environmental effects, it's social effects, which makes this even more challenging. It's really difficult to treat. And again, opioids relieve stress. So to finish, the only way we're going to effectively manage this is collaboration. And that's something that's been so remarkable for the past 2 years with the collaboration that's happened in this community. It's going to take every person in this room and all of the agencies and all of your passion to be able to get in front of this problem. I have hope because we're all here. But unless we work together, we will not be successful. So thank you for your time.